Okay, so this is take like 476. Apparently it's harder to record your voice than it is to just talk about it in the classroom. So today's topic is how do we find the acute MI in a patient with an abnormal presentation, specifically like ECG presentations such as left bundles, pacers, etc. Okay. And so the problem arises with these types of presentations is that they have inherent built-in ST elevation in their normal baseline presentations. And so if you are trained to just use the standard STEMI criteria that everyone is taught, the 1 or more millimeters of ST elevation in 2 anatomically contiguous leads, you're going to both falsely activate and miss a lot of acute MIs. Upwards of 20 to 30% of acute MIs actually present without these textbook STEMI criteria that we're taught. And so I don't know about you guys, but I would prefer not to 2 out of 10 STEMIs, or acute MIs, I should say. So here's a beautiful example. This, if you apply those criteria to this ECG, you're going to look at it and you might think, hey, I have an anteroseptal MI. I have ST elevation present in V3, V2. You can see where I drew a line there that there's clear-cut ST elevation, looks like about 3 millimeters or more in the anteroseptal region. And even down in V5, V6, you have some lateral changes as well. You have some flipped T waves. And so if you were to look at this and apply only those criteria, you might think, if this patient had a chest pain, hey, he's having a STEMI and we have to activate. Okay, here's another example. This is a left bundle branch block here. And so if you look in the anteroseptal region, you have significant elevation, or what you would perceive to be clinically significant elevation, and if this patient had chest pain, you might activate. And so for those of you, some might be saying, well, hey, what does it really matter? So we falsely activate on some, no big deal. You're going to miss some anyways. What I actually see in practice is that people, when they see ECGs that look like this, they actually tend to just discredit it completely, and most oftentimes just treat the patient like they're a standard unstable angina patient rather than actually treating them like an acute infarction. And this happens very much. I've been told many times, oh, it's just a left bundle. Oh, it's a pacer rhythm. You don't need to look any further into it. Treat your patient, not to monitor, which in certain instances I agree with, but in this case, you're going to end up missing some stuff. And so what is the problem here? Why are we taught that you can't see a STEMI in a left bundle? Why are we taught that you can't see a STEMI in a ventricular pacer rhythm? And the answer is discordance. The problem here is that in these types of rhythms, you have several leads that present with QRS complexes that are downwards and a T wave that is upright. And so anytime the QRS and the T wave are on opposing sides of that isoelectric line, we call that discordance. And when that happens, what they commonly don't teach you is that when a T wave is on the opposite side, it predisposes that ECG to having some ST deviations. What happens is that T wave, in essence, will actually pull the ST segment away from the isoelectric line with it. And so when the QRS complex is transitioning over into the T wave, you'll get that deviation, and it always will go with it. That's the key to look for. You can see here, I've marked again, we have significant, again, not clinically significant, but what might appear to be clinically significant ST elevation in V1, V2, and V3. This patient is not having an MI. This is a normal left bundle, albeit it's a pretty ugly left bundle. This is a normal left bundle, and then ST elevation is normal. Okay, so again, the problem is discordance. When your T waves are upright and your QRS is downwards, you are going to have a little bit of ST elevation. And the same goes true for the opposite. If you have T waves that are downward deflected in an upright QRS complex, you will get some ST depression. So why you've always heard you can't see a STEMI in a left bundle, but you've never heard that when you're talking about a right bundle, has to do with this exact concept, is that in a right bundle, and here's an example, virtually everywhere on the ECG, the QRS complexes are upright or the T waves are concordant. They follow the QRS complex. And so you're not going to get ST elevation. Now you can get ST depression. That is actually somewhat common in a right bundle depending on the presentation. Anywhere where you would have an upwards QRS complex and a downward flipped T wave, you could get some ST depression, and that's normal. But there's nowhere in a left bundle really where you have a relatively deep S wave with an upright T wave, and so you don't see the ST elevation. And so that's why right bundles are quote unquote considered still able to diagnose a STEMI, whereas you can't in a left bundle. But again, that's just it's a misunderstanding of electrophysiology and what's actually happening to the EEG. Okay, so to address this problem and these rules that these Sgarbossa criteria that have finally started to permeate into emergency medicine, these rules have actually been around since the early 90s. We're talking 20, 25 years. And so Sgarbossa was a cardiologist who actually studied left bundles and the presence of acute MI within a left bundle and developed these criteria. And here's a nice little chart that I stole off the internet that it's a nice graphic that demonstrates the three criteria that they created. And so the first criteria, criteria A, which is the presentation in the lower left, is what we call concordant elevation. And you can see here you have an upright QRS and an upright T wave with ST elevation. And so if that is present anywhere in the ECG, then that is predictive of an acute MI to an extremely high value. It's greater than 90% predictable of an acute infarction. Sgarbossa came up with criteria B, which is on the lower right here. And so for that one, it gets a little bit more complicated. So in part A, it was concordant elevation in any lead. And by the way, they never applied that it had to be two contiguous leads, which brings into question why that ruling ever got involved in our standard STEMI teaching, because it has no application. The Sgarbossa B criteria is ST depression present in leads V1, V2, and V3. Now, V1, V2, and V3, the QRS complex in a left bundle is always negative, and so you will have a downwards QRS complex, just like you see in the graphic, with an upright T wave. Now, based on what I had already talked about how the T wave pulling the ST segment with it, what you should expect here, if anything, is a little bit of ST elevation. But instead, what you're seeing is ST depression, and so if Sgarbossa B criteria was present, that was also extremely predictive of an acute infarction, even though you're looking at ST depression, which is typically only associated with ischemia or reciprocal changes. This is considered an infarction and is a STEMI equivalent, and you should activate on that. The last criteria in the original Sgarbossa criteria was Sgarbossa C criteria, and basically in this one what they said was we acknowledge that a discordant T wave will pull the ST segment, and so you can see in the graphic you have a deep downward QRS complex and upright T wave. But even though the T wave will pull the ST segment, what Sgarbossa identified is that there's something called excessive discordance, when even though the T wave will pull that ST segment, it only can pull it to a certain point. If it exceeds that, and in the original criteria they applied a cap of 5 millimeters, if it exceeds that amount, then it's considered positive, it's considered excessively discordant, and that ST elevation has to be the indication of an underlying acute MI in the presence of a left bundle. Now, in the data that they used because they applied this data to a ton of left bundles, it wasn't nearly as predictive. Sgarbossa C criteria was not nearly as predictive as the first two criteria that I just described. And the reason for that is that the human body does not operate on millimeters. It operates on ratios, especially when we're talking about electrophysiology. And so years later, they came up with a modification to the Sgarbossa C criteria, in which they said, okay, yes, we recognize that there is a thing called excessive discordance, that a T wave can only pull that ST segment so much, but rather than applying a cap based on total millimeters, we should use a ratio. And so what they found is the magic number is somewhere around 25%. And these here say a ratio of 30 or 33%, but 25% is the magic number you want to look for. And so what they're asking you to do is that if you have that discordance where you have a QRS complex on one side of the isoelectric line and a T wave on the other, you want to measure how much deviation there is and compare it to the overall size of the QRS complex. Because what they found is that the deeper that QRS complex is, or the taller it is, the more deviation you will see, and it still be considered normal, up to about 25% the total magnitude of the QRS complex. So what that means in layman's terms is if you have a QRS complex that is 10 millimeters deep, then you should not, and you have a discordant T wave, so you have a downwards QRS that's 10 millimeters and a T wave that's upright, any ST elevation that's less than 2.5 millimeters is benign and normal for that presentation. And this can be applied to all of the abnormal pathologies, whether we're talking about left bundles, ventricular pacers, LVH, even PVCs, even VTAC to an extent. You could actually apply these rules. These rules apply to all of them. Even a ugly looking ventricular pacer rhythm has rules it has to follow, and these are those rules. And so when you review these criteria, when you kind of get an understanding of what normal presentations are, I've actually dumbed this down a little bit, made it very, very simple, boiled it down, because I think some of those criteria are hard to remember. And so the rule is this, that the ST segment should never deviate from the isoelectric line in the same direction as the QRS complex. If you think back to the Sgarbossa criteria, that's all that they're saying. You know, Sgarbossa A was the concordant ST elevation. Well, if you think about it, if it's concordant, it's going with the QRS complex. In the Sgarbossa B was ST depression in V1, V2, V3. Well, in a left bundle, all three of those have to be negative. And so again, the ST segment would be moving with it. So with the exception of that modified Sgarbossa C rule, which talked about excessive discordance, if you set that to the side for a second, you can't forget it, but if you set that to the side for a second, if you can just remember this one rule and apply it to all of your ECGs, it will save you and maybe save a life. That rule again is that the ST segment should never deviate from the isoelectric line in the same direction as the QRS complex. If the QRS complex is going upwards, you should not have ST elevation. If the QRS complex is going downwards, you should not have ST depression, regardless of what the T wave is doing. Okay, let's look at some examples. So this example one, I apologize for the poor copy here. This is a left bundle, patient's having chest pain, and it was ruled basically that because it's a left bundle, we can't tell, and they didn't know if it was old or new, which by the way, that has absolutely no relevance in medicine. It doesn't matter if it's old or new, it has to do with these criteria. If you look at this for a second, this is a little abnormal. So it is a left bundle. You can see in V1 and V2 and V3, you have the downward QRS complexes, and the QRS complexes are wide. In V6 is upright with a discordant T wave. That's a very common presentation for left bundle. But if you look at this for a second, there's a couple abnormalities, and I'll zoom in where we need to focus. And so if you look at V2 and V3, you can see that there's ST depression present in a downward QRS complex. Okay? In fact, this T wave is actually flipped. You would have expected it to be upright in a normal left bundle. You can see that it's almost becoming biphasic in lead V2. And so if you really look at that, the QRS complexes are going down, and the ST segment is down as well. There's ST depression present in V2 and V3. This would be Sgarbossa B criteria, because we have ST depression in one of the three leads of V1, V2, and V3. And again, though, if you apply that rule that I had said, the ST segment should never move away from the isoelectric line in the direction of the QRS, and it is doing so. Let's look at another example. Okay. Now in this one, we have some aberrantly conducted complexes, ectopic complexes in V1, V2, V3 that you can see here in the middle here. Those are PVCs. And so again, most providers are trained that you can't see anything in a PVC, that they're just junk, they're random, chaotic electrical activity, and you have no idea what's going on. But that is not true. You can tell a lot from the ECG on a PVC. You can tell the direction, you can tell the origin of the ventricle by how it presents. And it has to follow certain rules. And one of those rules is this rule of discordance, and the same Sgarbossa criteria. You can apply it here. And so if you really scrutinize this ECG, and this patient's having chest pain, you might not see much. You do have some ST elevation present in V3 in the normal complexes, but it's possibly not clinically significant. But if you look closely at these PVCs and you apply that rule, that one rule that the ST segment should not move away from the isoelectric line in the same direction as the QRS complex, what you'll see is that you have Sgarbossa A criteria located in the PVC. The ST segments are elevated, the QRSs are upright, and that should not happen. Especially look at V2. V2, look at that PVC. The T wave is down, the QRS is up, and yet you still have ST elevation. If anything, you would expect a little bit of ST depression. That complex in V2 should look more like the complex that you see in V1, where the T wave is down, the QRS is up. In this case, the J point is almost isoelectric, but if anything, you would expect the ST segment to sag, and instead it's actually elevating. This patient had 100% LAD occlusion, and the best way to identify it was actually not in the normal complexes, but in the PVC. In the example 3 here, you have a ventricular pacer rhythm, and so that's commonly taught to just throw it out, that you don't even give a second look at it, that it's just chaos, you have no idea what's going on. And so if this patient was having chest pain, you would have to transport weight on troponin, sometimes a serial troponin. And remember, in an acute MI, troponin is not the first cardiac enzyme that elevates, it's just the most sensitive, that's why we use it. And so it can take hours and hours before your troponin pops. And so in this case, if you were to not activate, if you were to sweep this under the rug, the patient could be infarcting for hours before you identify it. So when you look at this, apply that one rule, that the ST segment should not deviate away the isoelectric line in the same direction as the QRS. And when you look at that, you're going to see this. And the red arrows here in V2 and V3 show you, and actually V4 would qualify as well, that ST segment is moving with the QRS. You have a downward QRS complex, upright T waves. If anything, you would expect a little bit of ST elevation, and instead what you see is ST depression. This is Sgarbossa B criteria. I put some green arrows over here to show you what normal discordance looks like. So in lead 3 and AVF, you have a downward QRS complex, upright T wave, you have a little bit of ST elevation, but it's not clinically significant. It's not 25% the overall magnitude of the QRS complex. This is normal ventricular pacer activity. Same thing in AVL. You have an upright QRS, downward T wave. It looks pretty good, looks isoelectric, but even you would expect, if anything, a little bit of ST depression. But over here in V2 and V3, that is abnormal. This person also had 100% LAD. And had we not applied this could have went missed simply because the patient has a implanted pacemaker. Here's another example. This is another ventricular pacer rhythm. You can see it with the dashes there before the QRS complexes. And so when you look at it, scan it, you look at the whole thing, you see a lot of discordant T waves, you see a lot of QRS complexes on one side and T waves on the other. You look, and then you come across V2 here. And when you hit V2, you notice that the ST segment is elevated along with the QRS complex and the T wave. So this is that would be, I mistyped there. I labeled that as Sgarbossa B, but that's actually Sgarbossa A criteria. And then if I also marked down in V3 because this is a little bit more subtle. Now remember, Sgarbossa C criteria was that even if the T wave is upright and the QRS is down, and that T wave is going to pull the QRS complex with it a little bit, it can only do so much. And when you actually kind of zoom in and look at this, that ST segment is elevated too much for how deflected the QRS complex. So if you measure it out, it actually comes out to about 40%. The ST elevation is about 40% the overall magnitude of the QRS complex. That's excessively discordant, and according to the modified Sgarbossa C criteria rule, this would also be criteria to activate. Okay, here's another example. This is another left bundle. You can tell that by the wide and deep S waves in the right precordials. You got the M notched pattern in V6. And so when you look at this, nothing might jump out at you. You see the QRS complex is progressing. You do see some ST elevation in V3, but again, the QRS complex is down, T wave is upright. It's not greater than 25%, so it's not clinically significant. But if you look over on the left side here, on the in the inferior wall here, you're going to notice that you've got ST elevation that's clinically significant. Yes, the QRS is down. Yes, the T waves are upright, but that ST elevation is greater than 25% the depth of that QRS complex. And I put a red arrow up here in AVL because you have the opposite occurring in AVL. You have an upright QRS complex and a downward T wave, but you have ST depression, which you would expect. But again, that ST depression is too great for how tall the QRS complex is. That's not that tall of a QRS complex. Looks to be, somewhere around 6 to 8 millimeters tall, and you easily have 3 to 4 millimeters of ST depression. That's clinically significant. That's Sgarbossa C. It's what we call excessively discordant. That's probably the most subtle and hardest part when applying the Sgarbossa criteria. And that's it. All you have to remember is that one rule that I discussed, which is the ST segment should never deviate away from the isoelectric line in the direction of the QRS complex, and that if the T wave is going to pull the ST segment, it can only pull it so much. And so if you have ST elevation or you have ST depression that's greater than 25% the overall magnitude of the QRS complex in the presence of a patient with a good presentation, you need to activate on that patient. That patient is having an acute MI, and you might just catch it. Okay, thanks guys. If I talked about anything like LVH or identifying left bundles or some of those things that I skipped over very quickly, I have videos made on all the other things from cardiac access to the bundle branches to identifying LVH and RVH in the ECG, and you can check those out to kind of go more in depth with those types of topics. All right, thanks guys.